All right, afternoon, everyone. I'm just watching the participant numbers tick up. Welcome to our 43rd seminar of the Centre of Research Excellence in Aphasia Recovery and Rehabilitation. I'm Dr. John Pearce, Research Fellow at the Aphasia CRE and co-facilitator of the series with Dr. Sonia Brownset. Before we do anything else, I'd like to acknowledge that this event and many of our participants today are located on the lands of traditional custodians in Australia. I'm speaking to you from the land of the Bunurong people, and we pay our respects to elders past, present, and future, and we extend this respect to any First Nations people joining us online. Today, really happy to hear from Dr. Jasvinder Sekhon, who's joining us to talk about a topic that, I mean, it's a very challenging topic, but it's so incredibly important. So I know people are really keen to hear what you've been doing, Jas. Before I formally introduce you, though, I'll just cover the housekeeping. So if you haven't already joined up with the Aphasia CRE, please do so. You can subscribe to the community of practice, and we welcome people with aphasia, their family, friends, health professionals, researchers, and organisations. And you can also connect with us on social media via Twitter or X and Facebook, and we also have a blog where you can subscribe to hear the latest findings, calls for participants, and other events. And as always, please feel free to tweet along with today's seminar using the hashtag AphasiaCRE. Please note that this seminar is being recorded for future viewing, and you'll be able to view that on our YouTube channel, which contains past recordings, and this seminar will be uploaded within a few weeks. During this presentation, I'm sure lots of questions will come up, so please ask these in the question and answer box at the bottom of your toolbar, rather than the chat box. You can ask that question at any point, and you can like or upvote questions you would also like to hear the answer to from other members. And at the end of the presentation, Jas will answer as many questions as time allows. Please ensure you ask questions only and keep your questions fairly brief. So I'm delighted today to introduce our speaker, Dr. Jasvinder Sekhon. Since graduating from Trobe University in 1992, Jas has worked primarily with adults with communication and swallowing disorders across the care continuum in public health in Victoria. Jas has worked in various clinical, academic and research roles, and she completed her PhD in 2022 under the supervision of Professor Jenny Oates, Professor Ian Kneebone and Professor Miranda Rose. Jas investigated counselling education for speech pathologists working in post-stroke aphasia rehabilitation. In a trial of a new education program, she demonstrated that speech pathologists improve self-perceived efficacy, confidence, and self-reported competence for counselling in aphasia rehabilitation. This program, called the CLEAR, standing for Counselling Education in Aphasia Rehabilitation, is now offered as a short course at Trobe University. And there's been interest for the CLEAR course from speech pathologists from the UK, United States, and New Zealand. So welcome, Jas. I'll stop sharing so that you can share your screen.
Thank you, John. So I'll share and tell me, can you see that okay?
Yep, that looks great.
And okay, fabulous. Thank you so much. Firstly, I'd like to acknowledge the Wurundjeri people of the Kulin Nation as the traditional custodians of the land that I live and work on. I wish to pay my respects to all elders for their wisdom. Thank you sincerely to the Aphasia CRE for this opportunity to present on the studies, as John mentioned, that I conducted as part of my PhD. And I'm deeply grateful to my mentors and PhD supervisors, as John mentioned, Professor Jennifer Oates and Professor Miranda Rose of La Trobe University and Professor Ian Kneebone of University of Technology, Sydney, for their guidance, patience, and expertise. I feel really privileged to have spent time with and learnt from the CRE staff, students, and the community of practice. I'd also like to acknowledge my clinical colleagues, the speech pathology faculty of La Trobe University, and clients with aphasia and families from whom I've learnt a great deal. I'm particularly grateful to the speech pathologists who have helped in this research, by participating in the studies in this presentation. Let me see if that, okay. So in today's presentation, I'll cover speech pathologists' counselling role for supporting psychological well-being in post-stroke aphasia rehabilitation and outline 4 studies that are aimed at enabling speech pathologists to feel confident in this practice. Heads up that there will be 2 QR codes to access the references and a protocol document later in the presentation, so keep your phones handy. Alternatively, you can email me and I'll send these documents to you. So stroke is a common, serious and disabling global healthcare problem, and one of the main causes of acquired adult disability, including aphasia. The most common cause of aphasia is stroke. Approximately 30% of stroke survivors are affected by aphasia. Communication disability from aphasia impacts greatly on stroke rehabilitation outcomes and on well-being. People with aphasia and their families experience significant emotional and psychological upheaval, including experiencing adjustment difficulties, distress, grief, anger, frustration, and mood disorders such as anxiety and depression. And the frequency of mood disorders is higher for people affected by post-stroke aphasia when compared to stroke survivors without aphasia. Stroke rehabilitation is a holistic, person-centered, and goal-oriented process that aims to bring about the highest possible function and participation in the person's community so that people can live their best life possible after stroke. Stroke rehabilitation requires timely and coordinated healthcare that is delivered by a multidisciplinary team. Stroke survivors with aphasia and their families and speech pathologists have identified psychological well-being as an important rehabilitation outcome in post-stroke aphasia rehabilitation. A stepped model for psychological care provides a framework for the assessment and management of emotional and cognitive conditions after stroke. The stepped model also provides a framework for the stroke multidisciplinary team in terms of their responsibilities and the extent of psychological support they may provide. A central tenet of the stepped care approach is that the whole multidisciplinary team take responsibility for the identification, monitoring, and management of psychological issues after stroke, with clearly established referral pathways to specialist stroke support services in the case of more severe psychological disturbances. So level 1 describes sub-threshold psychological problems common to most or all people with stroke. Psychological support at level 1 could be provided by peers and stroke specialist staff and is expected to be carried out alongside current discipline-specific therapy, for example, aphasia therapy. A range of interventions at level 1 relevant to speech pathologists include using counselling skills such as active listening, building effective relationships, educating, normalizing, guiding, and supporting. Using brief counselling approaches such as person-centered, problem-solving, and motivational interviewing. Self-care and managing stress, building skills for self-management and autonomy, goal setting and achievement, and enabling peer support and positive relationships, including providing communication partner training. Recommendations from the STEP psychological care framework specify that non-mental health stroke staff should be trained to be competent to provide psychological care appropriate to their role in the stroke team. A challenge, however, is that although counselling is a high-frequency practice in aphasia rehabilitation, speech pathologists report being underprepared for this role. Speech pathologists reported low counselling knowledge, skills, and confidence, and reported to want better training to feel skilled, confident, and prepared to address psychological well-being in aphasia rehabilitation. The 4 studies presented here today aim to investigate this question: what enables speech pathologists to feel confident and competent in counselling for supporting psychological well-being in people affected by post-stroke aphasia? The 4 studies included a systematic review, a survey, a randomized controlled trial, and a qualitative study. Just let me see. Yep. In our systematic review, we aim to identify education that enables speech pathologists to feel confident and competent to provide counselling aimed at supporting psychological well-being in this client group. Specifically, we evaluated counselling topics, methods of education, including for skills practice, the duration of education, and evaluation of competency for counselling. Out of the 9 studies that met the inclusion criteria, 4 studies described pre-qualification counselling training, and 5 studies described counselling training after speech pathology qualifications. Topics offered to American speech pathology students included general and specific counselling education, goal setting, and client-centered and holistic approaches. Education processes included observation, coursework, and practicum, and group learning with other disciplines, for example, social work. Hours of counselling education was unclear, but 3 to 4 hours was reported. After qualifications, some British speech pathologists working in stroke care received level 1 counselling training. Some speech pathologists also sought education from external sources. Speech pathologists reported a range of counselling education from nothing to PhD qualifications. Commonly, counselling education was between 1 to 2 days. Adult learning principles and viewing videos of counselling techniques were used. Counselling education and experience was positively correlated with feeling knowledgeable, skilled, and confident for supporting psychological well-being in post-stroke aphasia. At the time when we conducted the systematic review, we found no information describing pre-qualification counselling education for speech pathology students at Australian universities. So we conducted a survey with the aim to describe the current state of counselling education for Australian speech pathology students, and also to compare this information with the 4 American studies. The survey consisted of 17 closed questions and 1 open-ended question, taking approximately 20 minutes to complete. We invited speech pathology academics from New Zealand to pilot the study, and feedback was incorporated in the final distributed survey that was open for 6 weeks between October to December in 2018. So the survey was distributed electronically to 1 key academic of the speech pathology discipline at all 15 Australian universities that provided 21 speech pathology programs at the time. We received 12 responses representing 12 speech pathology courses, providing us with a 57% response rate. All respondents reported that the courses at the university provided speech pathology students with post-stroke aphasia rehabilitation education.
highlighting the important role of speech pathologists with this client group. But was counselling education to support the psychological well-being of people with post-stroke aphasia provided to speech pathology students? Of the 10 of 12 universities reported to provide counselling education, and of these, 4 provided counselling specific to post-stroke aphasia rehabilitation. So due to the way the questions were set, this question was not displayed to 3 respondents. Of note is that counselling education was not provided by all universities offering speech pathology education in Australia. So a variety of counselling topics were reported, with the most common topic being general principles of counselling. Motivational interviewing and cognitive behavior therapy were the most frequently reported counselling approaches taught. Other frequently reported topics included communicating bad news, professional self-care, counselling theories to develop the therapeutic relationship, and others on the slide. A range of methods of counselling education were provided. The use of role play and case discussions and problem-based learning were most frequently reported. Other popular methods included didactic lectures, tutorials, and watching videos of counselling techniques. Counselling education was evaluated by written and oral assignment, subject exams, reviewing of the videos and written transcripts of role plays, and problem-based learning or case study discussion. All of the 7 courses that reported to provide counselling education provided over 10 hours of coursework. The majority provided 3 hours or less of counselling observation and practicum, and a few courses provided over 4 hours of observational and practical elements. In contrast, most programs provided approximately only 3 hours or less of counselling coursework, observation, and practicum specific to post-stroke aphasia rehabilitation. All academics, except one in this survey study, considered counselling training essential to speech pathology qualifications. However, only 3 felt that students were competent in providing counselling to people affected by post-stroke aphasia. So from our survey, we concluded that counselling skills are essential to speech pathology practice and require education for competency. While the majority of speech pathology courses in Australia provide students with counselling education, some do not. About a third of speech pathology courses provide counselling education specific for working in post-stroke aphasia rehabilitation. However, it remains unclear if Australian speech pathologists graduate with competency for counselling in communication disorders, including counselling in post-stroke aphasia rehabilitation. So with this information, we thought that perhaps a targeted education program could address the gaps of counselling knowledge, skills, and confidence for speech pathologists working in post-stroke aphasia rehabilitation. We designed a counselling education program intervention that drew information from the STEPPED model for psychological care, the systematic review, and surveys of current counselling education for speech pathologists. So this QR code here links to the document describing the development of the counselling education course for speech pathologists for supporting psychological well-being in post-stroke aphasia rehabilitation. In this document, we describe the content and format of the education program, pedagogy, and the program development process. We proposed a framework for counselling in post-stroke aphasia rehabilitation for speech pathologists based on the Calgary-Cambridge model. Clinical communication is a complex set of skills that require development and training. The Calgary-Cambridge framework guides the teaching of these complex skills and outlines objectives to be achieved within a medical interview. 5 key tasks, including initiating the session, gathering information, physical examination and assessments, explaining and planning, and closing the session, are identified. Patient-centered healthcare is incorporated into both process and content aspects of the clinical interview. In adapting this framework for speech pathology counselling practice in post-stroke aphasia rehabilitation, we referred to other patient-centered counselling approaches, including single-session format, providing biopsychosocial patient-centered care, micro-skills, and the skilled helper model. In the first task, initiating the session, clinicians may prepare for the aphasia therapy session with any background information, resources, and communication aids, establish initial rapport, identify and clarify the reason for the consultation, collaboratively decide upfront on the agenda. That is, what would be the most useful and important thing to the client to gain from the session. In the next task of gathering information, clinicians aim to explore the client's story, strengths, and clarify or state the problem. Biopsychosocial information is gathered within the context of communication and swallowing disorders after stroke, and from the client, family, and any significant others. The clinician may be required to manage differences in perspectives and conflict within the family system. Relationships are developed, and professional, client, and family experience and expertise are brought together to collaboratively understand the problem, the story, and preferred outcomes. Further assessments may be required in the next task, followed by education and planning for how to achieve the client's desired outcomes, including goal setting. Tasks in this element may include providing the correct type and amount of stroke, aphasia, and health services information, aiding accurate recall and understanding by supporting communication and ensuring communicatively accessible information is available, and when this information is required, especially in transition between services or staff. Achieving a shared understanding by incorporating the person's values, resources, considering impairment, activity, and participation goals and hopes. Responding to emotions, using problem solving and motivational interviewing strategies in behavior change discussions, and building skills and support services for self-management. The final element is ensuring an appropriate point of closure and ensuring the client is clear about what the next step will be. Closure is not necessarily a solution or a cure, and the client is able to re-enter the services as required. So in case you missed it, details for the proposed framework can be found in the document linked to this QR code shown earlier. To test this new counselling training intervention, we conducted our third study using a randomized control trial with a delayed control arm. So speech pathologists working on rehabilitation goals with people affected by post-stroke aphasia in Australia were eligible to participate. The counselling education program consisted of approximately 7 hours of self-directed and reflective learning via La Trobe University's Learning Management System, Moodle, and one online workshop, which was delivered via Zoom and went for 3 hours. The course was delivered online as the trial was conducted during the COVID-19 pandemic. The 7 sections in the Moodle were represented by tiles on the landing page. Section 1 included information about the study and instructions how to navigate through the Moodle. Section 2 covered speech pathologists' role and responsibilities for supporting psychological well-being in post-stroke aphasia within a multidisciplinary team and the stepped model for psychological care. And the material in Section 3 aimed to improve speech pathologists' knowledge and understanding of counselling theory and foundation counselling skills, and to be able to apply these to speech pathology and in post-stroke aphasia rehabilitation. Section 4 introduced knowledge and skills required for recognizing and responding to a range of emotional and psychological issues experienced by people affected by post-stroke aphasia. Section 5 provided information about the workshop, which I facilitated. Participants were randomly sent to breakout rooms in groups of 3s or 4s, and were set activities to apply their new learning and to practice counselling skills in role play activities with their speech pathology peers. After each role play session, the group met for discussion relating to any questions or queries that came up during the breakout sessions. Section 6 described information about the nested qualitative study evaluating participants' experience of the counselling training, that is study 4, and when results summary were anticipated to be available, and about participants' certificate of completion. Section 7 included references and material used in the education program. The primary measure was the self-efficacy for counselling in post-stroke aphasia survey, which was adapted from Victorino and Hinkle's self-efficacy measurement tool for counselling in speech pathology and consisted of 35 closed questions. Participants were asked to rate their own ability as they perceive it to conduct the counselling skills effectively over the week ahead and with most clients with post-stroke aphasia and their families. Perceived confidence in using a counselling skill was rated on a 6-point rank scale, ranging from "I'm not familiar with that concept" to "completely confident." A secondary outcome measure created specifically for this study was the self-report of competence for counselling in post-stroke aphasia tool. This survey included 11 closed questions and explored possible counselling skills relevant to post-stroke aphasia. In the secondary measure, clinicians were asked to rate their confidence to recognize and respond to anxiety, depression, and suicide ideation. Speech pathologists were also asked to rate their confidence for managing their own psychological well-being and that of their colleagues on the stroke team, and confidence for using problem-solving and person-centered approaches with clients. The final question asked clinicians to rate their own competency for counselling people affected by post-stroke aphasia as part of their speech pathology role. The 6-point rating scale was similar to the primary tool. So our research questions were: what is the effect of our counselling education program on speech pathologists' self-efficacy and self-rated competency for counselling in post-stroke aphasia rehabilitation? And were effects of counselling education maintained at 5 weeks follow-up compared with post-intervention? We enrolled 51 participants and randomized 49, 25 to the intervention group and 24 participants to the delayed intervention group or the control arm. The intervention group commenced the 5-week intervention first, while the delayed intervention group waited. After measures at time 2 were completed, 24 participants of the delayed intervention group commenced their counselling education. In total, 41 participants completed the trial. Although approximately 35% of the participants reported they received counselling training for supporting psychological well-being as students, none had training specific to post-stroke aphasia rehabilitation. Here are some mean self-efficacy scores for the first 2 participants of the intervention group and delayed intervention group. You can see that all these 4 participants' scores increased markedly after intervention, and these gains appeared to be maintained at follow-up. This pattern is similarly so for the self-rated competency scores, but were these changes significant? Overall, for self-efficacy scores, there was a significant interaction between time and group, and a large effect size was observed. For self-rated competency scores, overall, there was also a significant interaction between time and group, and also a large effect size was noted. And were these effects maintained at 5 weeks post-intervention? The mean increase of 2.8 points in self-efficacy scores at follow-up was not statistically significant. However, there was a statistically significant mean increase in self-rated competency scores with a small effect size. So in summary, there were significant and large effects of the program on speech pathologists' self-efficacy and self-rated competency for counselling in post-stroke aphasia rehabilitation. The effects were maintained at 5 weeks follow-up for both self-efficacy and self-rated competency, with self-rated competency showing a significant increase at follow-up. In conclusion, we can say our online course improved speech pathologists' self-efficacy and self-rated competency for counselling in post-stroke aphasia rehabilitation. However, the program warrants future investigation with a definitive trial that is adequately powered and could include speech pathologists outside Australia to provide validation of these preliminary results. Qualitative information could provide insights to the learner experience and obtain information for improving the online program. And for the 4th qualitative study, speech pathologists who participated in the trial study were invited to volunteer their time to provide information and their opinions of the feasibility of the online format, usefulness and clinical applicability of the education program to their work in post-stroke aphasia rehabilitation. So for our 4th study, research associate not involved in the development or provision of the counselling course interviewed 6 speech pathologists within 2 months of completion of the counselling education program. Interviews were based on 10 guiding questions used in previous research by Northcott and colleagues. Data were analysed using framework analysis. The 6 speech pathologists who volunteered their time for this study worked in a variety of states across Australia and across a variety of stroke settings, including hospital, community, tele-rehab, private practice, and university clinic. All except one reported no counselling education as a student, but all had undertaken some counselling education prior to participating in the trial. In our preliminary results, we found that all participants would recommend the program to their speech pathology peers, and some thought it could also benefit speech pathology students. We identified 5 themes. The first is that the learning content was comprehensive, feasible, structured, useful, validating, and applicable to speech pathology practice in healthcare and post-stroke aphasia rehabilitation, particularly for early career speech pathologists and those without prior counselling education. Some quotes to support this theme includes participant 2 said, "It gave me good solidification of skills that maybe I had already, but didn't realize that I could build on and that I could use them for specific things." Participant 1 said, "It was logical and had a logical flow." Participant 6 said, "The most useful was having a framework and a structure to it." Participant 4, "I think it would be really good for speech pathology students to engage in something like this, to get them ready for the diversity of our role." And again, participant 4, "I think it was a really good length and a good format to meet my needs to be most useful." The second theme, the design of the content on Moodle was clunky, hard to navigate, onerous, and required too much reading. Participant 3 said, "I found the text quite unengaging. I probably would prefer some more video or audio content." The third theme was the workshop was an essential and important part of the program. Participant 4 said, "I found the workshops really valuable, and the pairs of 3 in my workshop worked really well. Everyone had slightly different styles and different experiences, and they came from different contexts, so I found that a really useful opportunity." We asked about enablers and barriers to apply counselling in post-stroke aphasia rehabilitation. So enablers to applying counselling in post-stroke aphasia rehabilitation included the multidisciplinary team and counselling training. Participant 5 said, "The pastoral care team that sits alongside allied health certainly do provide that wonderful emotional support." Participant 4, "Definitely the counselling skills checklist has been an enabler." So participants identified barriers to applying counselling skills in post-stroke aphasia rehabilitation that included people using counselling with people with severe aphasia and the lack of a multidisciplinary team in stroke rehabilitation. From participant 2, "I think the only barrier would be the really severe aphasic patient. I still don't really know how to approach that." And from participant 3, "I did have a great clinical supervisor, but I don't know that she'd had any training in psychological interventions. Yeah, and we don't have really that much access to psychology or anything on our team." So in conclusion, participants felt the program was a good introduction to counselling for speech pathologists. The design and delivery of the learning content in Moodle requires some refinement for better engagement and user experience. Counselling education and support from stroke specialist speech pathologists and mental health professionals who are appropriately skilled for supporting psychological well-being in people with post-stroke aphasia and their families are recommended. and research for supporting the psychological well-being in people with prior mental illness and severe aphasia after stroke was also highlighted. Okay, a final quote from participant 4 to sum up. I do really feel like the training, it does allow you to develop confidence to be able to do this work and be really certain that this is within our realm of practice. Using the feedback from the qualitative study, we've made improvements to the course and have launched a short course called CLEAR. CLEAR stands for Counselling Education in Aphasia Rehabilitation, and it aims to improve the knowledge, skills, and self-efficacy of speech pathologists to support the psychological well-being of people affected by post-stroke aphasia and their families. Of course, there are more questions to answer. Our survey evaluated counselling education within the university. Research into speech pathology counselling education in the field and during clinical placement outside the university is required. Since our survey in 2018, there are nearly double the number of universities and programs offering speech pathology courses around Australia. It would be a concern if speech pathologists are not provided with counselling education to meet professional practice standards. Perhaps counselling education should be essential for accrediting speech pathology courses. Aphasia after stroke can be chronic and a lifelong disability. More research is required to understand what supports clients' needs emotionally and psychologically across the continuum of healthcare. Our study reported on self-perceived confidence, skills, and competency for counselling. We don't know if this translates into actual or effective use of counselling skills in practice. So do speech pathologists use counselling skills in practice? And what are the effects of this practice on client well-being outcomes? Excitingly, a new network of researchers and the Aphasia Psychological Care Research Network was recently convened by Emerita Professor Linda Worrell with the purpose to connect and unite research efforts to improve well-being in people living with aphasia and their families. The network now has close to 60 international members and is led by Dr. Molly Manning and Dr. Sarah Northcott. So do keep an eye out for more developments in this space. Thank you so much for your attention and for this opportunity to present to you. Please feel free to contact me via email if you have any questions or comments about this presentation or want those documents. And you can scan the QR code here for the references in this presentation. So thank you again.
Thank you so much, Chaz. You really tackled that problem from start to finish.
Can I
I'm
stop
sure you're
sharing?
not done yet. Yes, if you could stop sharing. I'd like to ask just to start by asking you to describe kind of what you saw in your own clinical practice that tipped you into, you know, this path of a PhD and trying to address this problem.
Yeah, so quite a few things. I came across clinicians or leaders, experienced speech pathologists who actually felt that counseling was out of our role, which kind of conflicted with me. And also personal barriers with lovely psychologists and including neuropsychologists and clinical psychologists who had you know, felt underconfident working with people with post-stroke aphasia. So there's this real tension for me that I could identify, you know, the real grief, the emotional upheaval, the constant frustration, and the significant change that people experience in their life after stroke and aphasia. So I just felt really to start this journey was from my own learning that I just felt, you know, no amount of impairment-based therapy or activity or participant-based therapy addressed this gap of dealing with the person's emotion in the present moment. I was very fortunate to have many discussions with clinical psychologists and neuropsychologists and social workers. Social workers were a very integral part of our team, and learned so much from them to kind of figure that, speech pathologists have certainly a role to play and have great skills in this area to try to build that gap and work in an interdisciplinary way, I guess, in stroke rehabilitation.
And did you have pushback along the way about speech pathologists in this role, or was it pretty well accepted at that first level of the stepped care?
I think is when people were provided, the suggestion, it's almost like being given a permission to consider it. I certainly felt and knew a lot of clinicians who had skills in psychological care, whether they did other training, and many speech pathologists, as we found out, were seeking this training alongside, but the generic training of counselling, there's plenty of counselling training, may not address the specific needs of our client population. So I didn't feel, I think people were just ready, speech pathologists that I knew were very ready to accept this role, and may already be doing it, but would, I think bringing this to the fore kind of validated this role and responsibility and gave them permission to acknowledge that actually a lot of what we do is already counseling, but we may not know that we're doing it.
Yes. We have got a question demonstrating that people are ready. From Jill Whitaker. She says, I'm based in the UK. Could we, excuse me, inquire about participation in the validation stage of the research?
Yes, it's underway, Jill. Thank you very much. That's definitely, please get in touch, email me. I think that's definitely on the cards. I think we just need to get some resources, funding, and get ourselves organized, and maybe APC, the Aphasia Psychological Care Network research arm, can progress this along. But we, I think, need to take this and validate the study outside for speech pathologists outside Australia. Definitely.
And what would you say? I mean, you identified that at least some courses are providing general counselling training. What about people who would say, well, you can just apply, aphasia-friendly approaches to that? What are the specific needs for counselling people with post-stroke aphasia?
That's a great question, and I think a research question that needs to be answered, because yes, there is an argument that why a specific counselling training for people with aphasia couldn't a generic counselling trainings meet the needs of speech pathologists populations right across the lifespan and areas, education or otherwise. I personally think, look, having worked in adult rehabilitation for many years, I wouldn't know the issues, the emotional and psychological issues in the different client populations, and I feel I couldn't understand the journey, and therefore couldn't apply counselling skills appropriately or effectively in a population that I don't know much about. So I in the literature, it's not quite clear that the answer to that question, but I think that's it's something that we can look at.
Yeah. Sonia Brownstone asks, love that you've developed this course, and should it be a new specialty that perhaps we all have basic competencies, but that some specialize in further, as we do for dysphagia, voice aphasia? Should this be a new specialty?
I think so. I think, thank you for all these lovely questions, but yeah, is it an advanced area of clinical practice? It's a great question, and yes, we need to address this. I think from this course and from my learning through the duration of my PhD, yeah, it iterated to me that, and that stepped model again situated speech pathologists within the stroke rehabilitation beautifully for me. And I think I think it should be, these generic counseling skills should be for all speech pathologists right across the board, but specific, there are more specific areas of knowledge, skills, and understanding, I think, of what people with aphasia and their families go through that is an advanced area of practice. And so whether there are studies out there now looking, I know in fluency, there is a lot of, there is, you know, that counseling approach speech pathologists do to some extent. I don't know the literature, but I know certainly within different areas of our client population, there is focus of supporting the emotional and family-centered practice. I think that certainly can be embedded into the next iteration because aphasia affects families, and family centered practice is part of, it is an approach that I think needs to be integrated within the clear course. We have it a little bit, but as I said, it's a constant learning for me. The next iteration, I think, and whether what that element looks like, that addition looks like, I'm not sure, to be tested. You know, how is it a 10-week course? How much is do we need in any one? If we're sticking with level 1 and we are sticking, you know, understanding that we are within a supportive framework with social workers or people who have more training in mental health, but not the understanding that speech pathologists have with this client group.
Yeah, it's a tricky balance, isn't it? What's a keep
what's
in
enough?
And what's then specialty, and yeah.
Exactly. How far? It is a continuum of learning, but like any learning, as you mentioned, dysphagia, you know, it's a continuing area of growing practice. And I think one of the big questions needs to be that scope of practice and of clinical guidelines to document, to understand and address whether is it advanced, is it supposed to be an undergraduate, what level?
Yeah.
All of that needs to be nutted out.
Yeah. Ellen Bernstein Ellis says, wonderful work. Could you share your insights on what did or didn't work well for the practice scenarios? Were there a few that were particularly impactful?
Thank you. Yes. The thing for the workshop, for the trial, we had just the one workshop, and when we piloted, we found most speech pathologists jumped straight into the dealing with the person with suicide ideation or anger, you know, getting into the big emotions, and I think for the next iteration with the clear course, we're now running 2 workshops because that was again the feedback that they wanted a practice session to do the basics and go away, apply and come back and then get into the big emotions. So I think structuring it in a gradual way, get those skills practice. Some people have embedded those basics and want to get into the more counseling approaches, applying motivational interviewing principles, etc. But I think what worked, I think, was a structure. So we everybody practiced foundation skills in the first section, come back for group discussions, discussed, you know, issues. And I think the main issue was how to work with people who are nonverbal, the severe aphasics. And I think there's so much more work to be done because remember, they were practicing in, you know, embodying their own clients, but they were trying to be aphasic, but still, you know, it's not the real thing, I guess. Yeah.
So those earlier sessions, was it just a scenario, very subtle, emotional?
Yeah, the first workshop was divided into 2 parts. So it's a 3-hour workshop. The part 1 is practice your basic foundation skills of being person-centered, active listening, and the second part, okay, this person is presenting with anger or suicide ideation. Now practice your counseling skills with this patient or with this scenario, and off they went.
Time for one more question from Stephanie Dunn. She says, do you know what, and you might have already answered this, but do you know what the impact was on the patients and families who had seen a speech pathologist who's participated in the study? Did it improve their overall progress?
This is the next big question. Thank you very much. As I mentioned in that second last slide, this is really what we need to do now. Does the counseling education, do speech pathologists actually use these, change their behaviors in clinical practice, and what impact does it have on the client's well-being? We really need to do that next study. I know there's a study in Western Australia, an audiologist who's done a very similar study, using counseling education for audiologists, and they did that second aspect. So there is actually a framework for us to try to use in this next part of the study. But very much so, what we do as speech pathologists to improve ourselves is to improve clients' well-being and psychological outcomes. Psychological well-being outcomes or well-being outcomes from a biopsychosocial frame of view in stroke. So that would be something we need to find out. So thank you for your question.
You research in a space where there isn't a lot of research and there's a lot of questions to answer, right? So
yep, absolutely.
Great. Well, look, thank you again, Jaz, for your time today and for presenting all of that work. I'm sure there's going to be a lot of interest in CLEAR, the course.
Absolutely. Thank you so much again, and please feel free to email me if you have more. Thanks.
I'll just introduce our next seminar. We'll be hearing from Professor David Copland, whose seminar is titled "The First 4 Years of the Queensland Aphasia Research Centre, Are the Times Are Changing?" And that will be on Wednesday, the 25th of October. Have a look at us on Twitter or our blog for details on how to register. I'll see you then. Thank you, Dr. Sekhon.
Thanks.